Hello, once more from the main stage of Transcatheter Interventions Online 2024. I'm thrilled to kick off the second part of Day 1, delving into structural heart disease once again. Over the next 2 sessions, we'll focus on revalving for transcatheter heart valve failure. As always, expect exciting presentations and enriching discussions. We will help see live cases from both Emory University and Erasmus Medical Center. Joining me on the panel are esteemed experts Nicolas von Mieghem, Giuseppe Tarantini, and David Hildick-Smith. Let's get started. Before we get going, we'll start with a poll. What proportion of the overall TAVI volume will be revalving TAVI 5 years from now? Oh, can we show the poll? Well, with the audience answers, Nicolas, let's start with your presentation on procedural planning and simulation.
All right, so what I'm going to do in the next 8 minutes or so is discuss the procedural planning and simulation of these revalving transcatheter valve failure procedures. And these are my conflicts. Well, first of all, I think it's important to realize what the scope of the problem is. And let's just look at the spectrum of TAVI in failing surgical or transcatheter valves. And this is an analysis that I borrowed from Philippe Généreux and Marty Leon, where they looked in gray the total amount of valve-in-valve cases and then separated the valve in transcatheter valve versus the valve in surgical valves. And what you clearly see is that there is maybe a mild increase over time in the TAV in surgical aortic valve prosthesis. But what you also can appreciate is a dramatic increase in blue that is expected in the need for treatment of failing transcatheter heart valves. Obviously, that is because we are treating much more patients with TAVI these days than with surgery. As a matter of fact, in the United States, several years ago, but also since 2 years ago, also in the Netherlands, we are doing more TAVI procedures than surgical aortic valve replacement. And that is basically also translating into a dramatic increase in the relative proportion of TAVI in failing transcatheter heart valves. And here you see in blue the overall TAVR market, and you can also see that this fraction of valve in transcatheter valve procedures will increase ×6 over the next 10 years or so. There are also 2 prospective studies ongoing on this topic. On the one hand, you have the RETAVI trial. This trial is led by Giuseppe Tarantini and Radek Parma. And there's the Revalved study that is led by Dan Blackman. Both trials are supported by the 2 main strategic partners in this field. And they have core labs for echo and CT scanning, 150 patients in the RETAVI, 300 patients in the Revalve study. So substantial studies that definitely will help us understand better the complexity of patients with failing transcatheter heart valves and how to treat, but also how to plan them. And for instance, the Revalve study has an interesting sub-study where specifically we will look at procedural planning and simulation using dedicated software. And I just want to illustrate 2 software programs that are out there that we are also using these days in our own practice and that we will also showcase in the live case an hour or so from now. One is FEOPS and the other one is Materialize. The Mimics Materialize and the FEOPS Heart Guide software programs. And basically what you do is you upload the CT scans to an external server. There is all kind of processing going on, and then you get back a product that allows allows you to basically appreciate a valve simulation. So you can see how a transcatheter valve will be landing in a failing surgical or transcatheter valve, and how then this valve will be relative to the coronary ostia. And you can then play around with the depth of implantation, with the commissural alignment, and you will get enhanced insights into also what's going on with the leaflets of the degenerated heart valve. And this is an appreciation how it looks with the FEOPS system. So you, let's see if it works. So you can simulate the implantation of a sapien valve in a failing evolute valve, as demonstrated in this example. And then it becomes clear what the distance, the distance is between the frame, the nitinol frame of that evolute valve and the coronary ostia. But also it will help you understand how leaflets are being pushed aside and how a neoskirt is formed. And then you can play around. You can modify the implantation depth, and obviously if you implant higher, then you will be relatively in a different position relative to the coronary arteries, and that obviously can become a tricky situation, as is demonstrated on the right-hand side of the panel, where you have a relatively high implant of the failing evolute valve, and if you then revalve it with a sapien valve with a low implant, you will stay away from the coronary ostia. If you aim a little bit higher at node 6, well, then you will jeopardize coronary access down the stretch. So what are the key essentials of revalving procedures? Well, you need to know the valve to coronary ostium distance. You also want to know the valve to sinotubular junction distance. The implant depth of the second transcatheter valve is going to be important because it will determine the neoskirt. The leaflet overhang is important, although the last year or so, I started to realize that the impact of leaflet overhang is not as large as we initially thought. So I think a large neoskirt can become more problematic. So that helps you also in understanding. If you implant higher with your revalving, you will have a larger neoskirt. If you implant somewhat lower, you might end up having more leaflet overhang, but you have a smaller neoskirt, and that might be favorable. And obviously, commissural alignment is also important in terms of coronary reaccessibility, as Giuseppe will hopefully explain to us later on. But basically, when you do a revalving, so a valve in a failing transcatheter valve, you will have 3 layers of skirts. Well, first of all, you have the aortic wall, and then you have a first outer skirt of that first transcatheter valve that has been degenerating. Then you have the nitinol frame of the evolute valve, for instance, and then on the inside you have the bioprosthetic valve leaflets. Well, you start to revalve, so basically you put again another metal frame in this case it could be a cobalt chromium if you have a sapien valve, and then again you first have the sealing skirt on the outside, and then you have again a metal frame, and again the leaflets that are on the inside, and then on the inside you have the bioprosthetic leaflets. So basically that is what you have to take into account, and you can already envision that as you are doing valve-in-valve procedures, also your residual area is becoming smaller and smaller. So there should be a limitation to the number of revalving procedures that you can do, and as a matter of fact, we have been simulating this with my fellow Mark van den Dorpel and also the FEOPS people, and we hope to report on that soon. And this is an example then from a recent publication by Dr. Dargan and colleagues, where they simulated a revalving procedure of a failing evolute prosthesis, and where they then simulated different implantation depths of a sapien valve to revalve. And basically the optimal assessment was in the middle, where they implanted this sapien valve at the level of node 5. By doing that, they had the sweet spot between the formation of a neoskirt that might impede coronary access and otherwise excessive leaflet overhang that might maybe impact valve durability over time. I think this was very nicely demonstrated, that the simulation corresponded very well with the final result that was confirmed by CT after the revalving procedure. And this is another software program that I already mentioned. This is the Materialize Mimics Planner, and again, you can simulate, for instance, here a failing surgical valve that is being treated with a sapien valve, and it becomes clear that as you are implanting the valve, you can then do all your measurements relative to the coronaries. You can measure the valve to coronary distance, the valve to sinotubular junction distance, but you can also make it more visible. And as an operator, obviously, that enhances your pre-procedural planning capabilities, and you will get a better understanding of what to expect during these procedures, revalving procedures. But they also give you basically some kind of a hint of what is possible as you are revalving failing transcatheter valves. So in conclusion, TAVI has definitely surpassed TAVR as the preferred therapy of severe aortic stenosis. The frequency of transcatheter valve failure is expected to increase. We have to accept that revalving is the therapy of choice for these failing transcatheter heart valves, and I think CT modeling and simulation may complement revalving planning. Thank you for your attention. Open for questions.
Thank you, Nicolas. That was an excellent demonstration of just how challenging this is. How often are you seeing in your practice failing transcatheter valves?
Well, it is on the rise as the expectations are. I think it's now around 5% of the overall volume versus 10% of the failing surgical valves.
Yeah, the AATS reported that it's the TAVR removal is the fastest growing surgical procedure right now. And I think in surgery, we're expecting this tsunami of failed valves. So Giuseppe, talk to me a little bit about what your team is doing in terms of planning the first valve for the second valve. Should this be critical in lifetime management? I think you're muted.
So first of all, thank you for having me. It's a pleasure to be part of this very important meeting. So actually your point is very important, but actually this will be also the focus of my presentation. Just to summarize, the first cut, what I used to say is the first cut is the deepest. So based on the anatomy of the patients, the first THV selection matters a lot in terms of the possible permutation that you can choose for these patients. Because actually, you were saying before that TAVR explantation will increase, but when you go for TAVR explantation, you need to know that the prognosis is worse, because at 1 year, the outcome of mortality is very different. So the point is that we need to think at the first attempt to select the first valve as the most appropriate, to avoid to go for TAVR explantation, and to prefer what is preferable is to go for THV and THV. But we need to do a perfect selection at the first attempt.
Excellent points. And Nicolas, your simulation, are you using that for TAV and SAV also? And how different is that workup for a TAV and SAV versus a TAV and TAV?
Yes, we are doing systematically now these pre-procedural plannings also in our failing surgical valves. I find them somewhat easier because with the transcatheter valves, oftentimes you have these longer valve frames, and that adds complexity to the simulation, but it also gives you more items to look for during your simulation processes. So yes, we are doing it. I think the focus again there is also on making sure that you have coronary access. Obviously, we are familiar with the externally mounted valves like the mitral flow that can become more cumbersome. And I think there the simulations can be very helpful and help you with the decision-making process of moving to a snorkeling bail or snorkeling procedure or a basilica procedure if needed.
Giuseppe, any final comments? I believe you're muted again.
You're muted.
Actually, it's for sure a role for the artificial intelligence, not only the simulation, but actually what I see is that we need to gather all this picture, and actually we need to come up with an algorithm that gives some, what is, the preferable strategy in terms of the valve, the positioning, the size. And this is, for me, the place of the artificial intelligence in the next upcoming years.
Wonderful. Well, actually, we're going to move right on to our second presentation, and you're going to talk to us about future coronary intervention. And I think, this just adds to the need for simulation and being able to predict exactly where the first valve lands. So take it away.
Thank you. Put up my slide, please. Okay, first slide. Can you carry on with my first slide, please? Okay, this is just to recall that there is a consensus document from EAPCI related to the issue of coronary artery disease in the setting of transcatheter valve. Next slide, please. And this is just to recall that at the end, on top of the CAD evaluation, timing of PCI, what is important is to look at the coronary access that is mainly grounded on three principles. The first one is the TAVI choice. So what I was saying before, the first cut is the deepest. Second point is the implantation technique of the first technology, the first the chosen THV. And third point is the commissural alignment or coronary alignment. Next slide. We know that not all the self-expandable valves are created equally. If you look at the cell area, for instance, we have with the accurate Neo2, we have 2 centimeters. So we have an open window of 2 centimeters that permit an easy access of the coronary when the valve is well oriented. We have other valves that are more close cell, like the Evolut family, that is about 4 millimeters at the level of the waist. So it's important to know all these things on top of the difference in terms of the asymmetric and the tent at the level of the commissure with the width that is different from valve to valve. Next slide, please. Another important point is the commissural alignment. I would like to be very clear for the audience of today. We don't need to go for the perfect alignation, but the real goal is to avoid the complete misalignments. That means that we stay for the tall frame valve with the commissure in front of the left main or in front of the coronary. This is something that we need to avoid. Next slide. This is what we have to avoid. Avoid severe misalignment. Next slide. Okay, stay here. So based on the forecast, angio-based and CT-based forecasts, different groups, that is, one is Padua, the other one is US at SIM group, and the other one is the Baker. As you can see, when you go with the supraannular valve as a first valve, and you go with the second valve that used to be a short valve, you might have some kind of impairment in coronary access that is present in 2/3 of the cases. On the contrary, when you go with a short frame valve and you stay below the coronary, the risk of having an impaired coronary access is lower, is 1/3 of the cases. Next slide, please. And actually, we have different combinations also. We can start with a short frame, and we can go in with a tall frame. We can go with a tall frame with an open cell that is 2 centimeters. But we have to think that when we go as a first valve with a tall frame valve, and the second valve is again a tall frame valve, on top of the consideration that said before Nicolas about the struts of the leaflets and the neoskirt and so forth, we have to consider another thing. It is the misalignments of the struts. Even though you get rid of the leaflets, you may have a misalignment of the struts. At that point, it's very difficult to get through, even with a 4 French catheter, if you have a full misalignment. it. It's, in real case, this is, a random effect because it's different from the bench test where you can align perfectly also the cells. And this is an example of a tall frame where it was not able, where we weren't able to get through with any catheter, and we can visualize the coronary, but it was not possible a selective cannulation of the coronary artery. Next slide, please. So this is a very central concept. So we have three different scenarios. The first one is when you use a short frame valve, like the surgical valve, like a short frame valve, and you stay below the coronary. In that case, the coronary cannulation is very easy. Second case, that when you use a tall frame, and actually you've seen in the previous presentation that there is a wrist plane or new skid in case of THV and THV that may impede to get through with the catheter. But when you have a roomy VTA, that is the extra valve space, extra frame space, the distance between the frame and the aorta, you can get through the coronary from outside. So the VTA is very important. When you have a VTA that is very, narrow, below 2 millimeters, even though you go with a short frame valve, but you stay above of the coronary, you can create a sinus sequestration because it's very difficult to get through with the coronary. Next slide, please. And actually, this is a very central concept. When you use a short frame valve like the surgical valve, the most important distance is the VTC, the distance from the frame to the coronary artery. In this case, let's figure out that we have two cases with a VTC that is roomy, more than 4 millimeters. But if you go with a tall frame valve, and on the right-hand side, you have an ST junction that is very narrow, you have to consider that what is really important is to calculate the VTA. Because if the VTA, next slide, is...
If you have smaller anatomy with lighter calcification, as we just did in our live case, you may well take the Boston valve. So there are a variety of anatomical subsets which allow you to choose exactly the right valve for your current situation. So those are the key factors that you need to bear in mind. At the same time, you do need to keep an eye on the future. So if we think about projecting 10 years and our patient comes back for a TAVI inside their existing TAVI, what are the major risks that they might face? And there are really three key risks that they'll face. The first is coronary occlusion. The second is difficulty or inaccessibility of getting to the coronary arteries, even though they're patent. And the third is a combination of patient prosthesis mismatch / higher gradients / lower valve area because of the crowded annulus. So looking at those each in detail. So coronary occlusion, of course, is the most feared risk. You can see here on the left-hand panel, occlusion of the right coronary artery. It's a dominant vessel, the heart's beating slowly, the patient is taking agonal breathings. If you can't open that up, your patient could be in very serious trouble. So this is an appropriately very feared outcome. Now, if we're putting a valve into this type of anatomy, really you are free as far as redo TAVI goes, because they're very capacious sinuses, the sinotubular junction is broad, you can put whatever valve you like in here, and there's going to be loads of room for putting in another valve. So this is a lovely anatomy to be doing, bearing in mind a future TAVI. However, on the contrary viewpoint, if we're putting a valve in this situation, and if this patient is someone who might come back for valve-in-valve TAVI, to have done this will present you with difficulties. You will definitely have to consider valve leaflet modification here because the S3 is quite cramped, the sinotubular junctions are tight, the the sinotubular junction is short above the annulus. The sinuses themselves are tight. There is no space here. You will inevitably jail the coronary arteries, both left and right, if you simply place a new valve in there, because the leaflets of the old valve will simply sit straight up and occlude the coronary ostia. So in this case, you would, if you were keeping an eye to the future, look at it and think, okay, instead I'm going to place a self-expanding valve that maybe tapers a little bit. I have to have a chance of having access to the coronaries later. I may choose to put the valve slightly lower than this. So coronary occlusion is definitely the most feared risk. And I think Francesca mentioned this earlier in her presentation, that although we've got obsessed with high placement of TAVI valves, that's actually not going to be super helpful if we have somebody coming for a redo procedure. If we have the valve high enough that it's actually impacting on the sinotubular junction and you might get sequestration of the sinuses, you could quickly be in significant trouble. So slightly lower placement of that first valve may be wise. The conducting tissue may be actually more resilient than we think in younger patients. So these are considerations. And this is especially true for valves which are straight-sided rather than tapered, and in the anatomy that I've mentioned here. So that's number one, that's coronary occlusion. Number two is coronary inaccessibility. So of course, nobody wants to be needing to get into coronary arteries and struggling, as we have just discussed, and therefore commissural alignment of the first valve can be helpful. It's very much a secondary objective, and it's something that shouldn't detract from your main aim, which is, of course, to get your valve in the right place without causing any complications and without having any aortic regurgitation. But if you can also align the commissures, that's an added bonus. And actually, we just discussed this again in our live case half an hour ago. Here you can see, for example, that the really key thing not to do is not to perfectly misalign the commissures. If you do that and land your commissure right in front of the left main stem, that's going to make things more difficult. You're going to have to be trying to poke at the artery from the side to get into it. It's not ideal. So long as you avoid that, you've really helped for coronary accessibility. Now, valves can be rotated to a certain extent. The core valve can be, the accurate neo can be. In due course, the balloon expandable valves will show some rotational capabilities as well, and that I think will be helpful. Serving the commissural anatomy that's already there, I think, is a naturally sensible and helpful thing to do, and increasingly we will do that as a matter of routine. The third and final thing is the patient prosthesis mismatch, higher gradient, smaller valve area. This is, of course, inherent to valve implantations. You have a Ukrainian doll situation where you have a doll inside a doll inside a doll. Of course, they have to get smaller. The annulus is crowded. The valve area that you can therefore get is going to be less good. So pre-dilatation of that existing valve will probably be helpful to make sure that you're maximizing the available area into which your new valve can go. Probably avoidance of too much intra-annular valve technology may be helpful. You want to take advantage of the supra-annular capability of circularity and increased orifice area and reduced gradients, because of course these do match in the longer term with outcomes, with valve degeneration over the long term. So a couple of simple examples to finish with. Here is a case where there was a core valve in place. It was leaking more than the patient was tolerating, though not terribly. And at the time, this was 6 years ago or so, we put a Lotus valve inside it. Now, that worked very well, and the patient has actually done well. But it's not something that we would consider doing now because it's well, apart from the fact that, of course, it's no longer available, sadly. The fact is it's an intra-annular valve. The gradient that would be obtained is going to be significantly raised, and therefore it's a valve that would not be perfect in this situation. You also have the potential for some leaflet overhang if you place the valve low. So another alternative would be to place an S3 inside a core valve. Now, in this particular case, it's placed quite high at an annular level because you can see that the core valve itself had been placed at a sort of 2007 height and was much too low for the coming anatomical implant of the second valve, although it actually made this procedure pretty straightforward. Normally, an S3 inside a core valve, which is probably a very good option, would be at around node 4 to get good hemodynamics and avoid any risk of embolization. And in this setting, the coronary risk would be low, there would be minimal leaflet overhang. And finally, a case of an S3 that had developed bioprosthetic degeneration, into which I hope you can see clearly here an accurate NEO has been placed. Now the crowns, the upper crowns, are just at the top of the S3. So this valve is sitting in a very nice anatomical situation with the supraannular nature of the valve respected there. So that accurate inside S3, also a good option. Good if well positioned with the upper crowns above and with lower gradients. So I think you can see that there are lots of ways in which we're going to learn about TAVI in TAVI over the years. Some of it is going to be quite complicated and theoretical, but at the same time, we're going to have to keep a few pragmatic principles in mind in order to be able to do these cases safely and effectively. Thanks very much.
Thank you for that. Great presentation. You know, there's this theme in the US that the balloon expandable valve is the right valve for revalving, and it's the only one that's approved actually in the US right now. Giuseppe, what are your thoughts on that, being that dogmatic, saying short valve is the valve to go for the second valve? I believe you're muted.
So what I think is that in Europe, short valve is the only one that has a CE mark for revalving. So this is the point. And as far as I know, also in the registry of core valve, actually, you know, for the second valve, you know, the point is to going with the short valve, you reduce the risk of struts and struts misalignments. And also you may reduce, in case of insufficiency, the risk of, you know, having a very high neoskirt and risk of coronary occlusion. So I'm not fond of the tall frame, to be honest, because actually, even though you get rid completely of the leaflets, you have the struts with the cell size that is very small, and sometimes you have the risk, even though without leaflets, to get through with the coronary. So for me, the second valve in the vast majority of cases will be the short frame valve. This is what.
Yeah, and we saw some demonstrations of tall frame valves being used, and so certainly it's going to be specific to those patients. And just to clarify, I was only speaking of TAV and TAV. For TAV and SAV, both are approved in the U.S. But let's go to the polling questions, because I want to discuss some of these findings, and I'm interested to see what the audience has. So let's go to poll question number 1. All right, David, what's your thought on this?
Wow. Well, that's really interesting. I mean, I think it's wrong. I think it's the wrong approach. You know, I think really, you know, quite often in medicine, people say, oh, I'm not going to give you the painkiller because although you've got pain, if I give you the painkiller, there's a risk that you might bleed. but instead of treating the real thing, they defer and give primary position to the theoretical risk. So this is the same. What you really need to do, in my mind, is you really need to give the patient the right valve for now, because only a small proportion of them are actually ever going to come back for TAVI and TAVI. Yes, of course, you need to have a mind's eye on what might happen under that circumstance. So you need to be aware of it, but primarily you should be giving them the right valve for their current anatomy.
And I would agree with you. This is something that I've often said in terms of coronary access, right? So you're planning for something that's likely not going to happen. But
Exactly.
Giuseppe, you have a different opinion?
Let me say something, because I agree to disagree. And this is the reason why I say that, because actually I think the two options of David are pretty much the same thing. Because when you say I need to fit the anatomy, it means that if I fit the anatomy, I'm able also to do redo and all the other things. So I think it's a little bit tricky that the two answers are not, for me, it's a little bit misleading, because the real point to me, when you deal with a 70 years old, healthy patient of 70 years old, we need to admit, and I think we need to be fair to say that we have two global leaders, because you have to consider the durability of the valve, not only the feasibility of the intervention. Feasibility of intervention is important. Actually, when we deal with the 85 years old, 90, and actually when we deal with 70, on top of the feasibility and the respect of the anatomy, we need to think also at the durability of the valve and the possibility to repeat the intervention. For me, these are the two main concepts. So for 70 years old, we need to go with the two global leaders that has 4 and 5 years of follow-up. And we know that the result is pretty much stable, with the mortality of 10% up to 4 to 5 years, without any difference between tall frame, cord valve, let's say family, and Sapien family. The second thing is the coronary access. So what I think is that, I don't know, David, if he's with me, when you have a very wide ST junction, you can choose one or the other. This is not, you don't have any problem. So the point is that when you have a very tight and narrow ST junction, and I think for the audience, what is important is one of the last slides of David, where you see that when you go with a short valve, but you stay above the ST junction, it is very narrow. There is no difference with a tall frame valve. So this is the most important concept to, as a takeaway of this discussion. So it's not matter of tall, short, it's matter of how much is the width of the ST junction and where you position the valve. Because if you stay very high with a short frame, it's pretty much the same to go with a cord valve. There is no difference.
Well, very good. We're running out of time for this session, so I do want to get to that last polling question, because I too am curious what the audience believes is best. Very interesting results. David, I'm going to give you the final word on this, and then we need to go to the live cases.
Yes, that's interesting. And the reason I wanted that question is just I wanted to see if it would be any different to, if you like, the absolute standard proportions of cases. And actually, that's interesting, because I reckon that's a slightly lower proportion of Edwards valve than average. Of course, it depends who's watching, but internationally, I think that's ever so slightly lower. But it's not far away from what you'd put in, irrespective of a future TAV and TAVI. So I'm sort of more or less reassured by that one.
Yeah, and certainly we don't have all of the durability data and what we really need to understand the right answer right now. And so those low-risk trials, the future trials that are ongoing, that will really help us answer the question, but interesting results. Well, it's been a pleasure to listen to such insightful presentations, and the discussions that have followed have been incredibly educational and motivating. It is now time to move to the next session, where we have 2 TAVR cases.